Thank you, Dr. Garg. So I'd like to introduce our first speaker, Dr. Thomas Kent. So Dr. Kent is both a clinician and a scientist with a focus in vascular neurology. He came to us from Baylor College of Medicine in 2018, where he was Director of Stroke Research and Education and Chief of Neurology at the DeBakey VA. He is currently professor at Texas A&M Institute of Biosciences and Technology on their Houston campus. Here at Houston Methodist, he is adjunct professor of neurology and radiology and a member of the Methodist Research Institute. He has made several fundamental contributions to stroke treatment and will be presenting his work on glucose dysregulation this morning. Thank you, Dr. Kent.
Thank you, Dr. Zhang, for that nice introduction, and good morning to everybody here and online. So today we're going to talk about patients that do not seem to get as well as they should from our stroke therapies. The topics that we're going to discuss today is we'll discuss a common metabolic condition that appears to worsen stroke outcomes after therapy. Then we'll discuss how this might disproportionately influence ethnic, racial, and sex differences in stroke treatment outcomes. So we'll hear today about remarkable advances in the last few years in acute stroke care, but nevertheless, some patients aren't getting as better as others. Outcomes improve dramatically for patients that qualify for endovascular thrombectomy, especially using the latest generation of devices and imaging modalities. And nevertheless, thrombolysis also still remains an integral part of our stroke therapies. But who is still not getting maximal benefit? And it turns out that a significant portion that have disorders of glucose metabolism. From very early days of preclinical stroke research, actually in the 1950s and 60s, through analyses of TPA data sets, and now to the modern endovascular series, one patient group has stood out as having the poor responses. And those are patients that are hyperglycemic on stroke presentation. So what glucose is too high? So very high and very low glucoses have long been listed as warnings about administration of TPA. That was originally done because these are known as are well-known stroke mimics. Both low glucose and high glucose can cause sudden onset of focal deficits. But animal research first and then analyses of clinical data suggested that high glucose also itself worsens the outcome. And amazingly, worse outcome starts at pretty low glucose levels, 140 to 150. If you look at the average median blood glucose in stroke randomized clinical trials, it's right around 140. And interestingly, outcomes are particularly worse in non-diabetics, those patients with normal or slightly elevated hemoglobin A1Cs, and we'll talk about why that might be. Then what do we mean by worse outcomes? About a third of acute stroke patients have glucose levels greater than 140. If you're treated with TPA, hyperglycemia predicts a 5 times greater chance of symptomatic hemorrhage, a 2-fold higher acute mortality, and overall reduced chance of a good functional outcome. If you're treated with stent retriever devices, it's very similar. 4-fold higher chance of hemorrhagic transformation, 2-fold higher mortality, and more than a 1/3 reduced chance of a good functional outcome. Why are patients hyperglycemic when they present with an acute stroke? Well, many of you are thinking that high glucose can be considered a stress response. So you have a large stroke, you have a higher glucose, and that's probably the case. But animal models where you can control for the ischemic insult still show that high glucoses can change the outcome. So this is the only basic science I'll present this morning, but in this study, we took a rodent model of middle cerebral artery occlusion. You take a catheter, just like endovascular therapy, and you can occlude the base where the middle cerebral artery comes off, and then you can reverse that by pulling it out. So if we reverse it in 60 to 90 minutes, and we have a normal glucose here on the x-axis, infarct size is pretty much restricted to the core of the most ischemic area. But simply by having rodents with different baseline glucose levels, you can increase the infarct size until you reach the maximal middle cerebral artery territory. So simply by changing glucose, you can drive the size of the infarct. Well, these are animal studies, which are fine, but what about clinical studies? So clinical studies can use databases, but they need to match for certain characteristics, and this can be done by a variety of ways. Propensity score can be used, although that's usually valid for larger samples, or other methods. One that we developed is called a Euclidean matching, or you can try to model NIH stroke scale, stroke severity, age, etc., and separate out the effects of high glucose. If you do this, you still show that high glucose at the time of admission predicts a worse outcome. So it's probably not just a stress response, but there still may be susceptibility to having a high glucose when a patient presents with their stroke. We'll talk about that. It goes beyond that a little bit, that it looks like hyperglycemia worsens outcome in a certain subset of stroke patients, and those are with large artery atherosclerosis. So plaque in the carotid artery, the basilar artery, the middle cerebral artery seem particularly to be susceptible to having a high glucose at admission. And in this study we published a few years ago that if you looked at patients with glucoses above 150 or below 150 and you matched them for their baseline characteristics, you ended up showing that half of the patients with large artery atherosclerosis had a worse outcome from TPA if they were hyperglycemic. There was a little bit of effect in embolic etiology and no effect in small vessel stroke, but the effect seems primarily to occur in those with large artery atherosclerosis. How might hyperglycemia worsen outcome? Well, high glucose is a real oxidative stress. It actually undergoes auto-oxidation. It causes other problems intracellularly and signaling mechanisms, and it can injure neurons, astrocytes, and other cells. But stroke-related worsening appears primarily to be because of damage to the cerebral vasculature, the endothelium and vascular smooth muscles. And it seems particularly damaging when those vessels are reperfused after they've been ischemic for a while. Hyperglycemia can rapidly, within minutes, cause a hyperthrombotic and a vasospastic phenotype of blood vessels. So how might this manifest itself? Well, if you're doing endovascular therapy and you're doing an angiogram post-thrombectomy, you might see poor reperfusion even though you achieved recanalization. You might see a rapid reocclusion in a hyperthrombotic state. You might see fluctuating perfusion if those vessels are spastic, or you might see distal occlusions. And everyone that's done endovascular therapy have seen this phenomenon in the acute setting. If you're using imaging to follow your patients, you just simply may fail to reduce this increasing size of a diffusion lesion on an MRI or the size of an infarct on a CAT scan. Why does this happen? This happens because glucose causes a lot of different kinds of pathology at a signaling level. So this is a paper we published quite a while ago. It's actually been cited about 300 times, and just in last year, it was cited a dozen times by endovascular therapy data sets that are all showing the same thing, that hyperglycemia does indeed worsen outcome, even with the most modern of techniques. So it looks like glucose sets the stage when you have ischemia by activating oxidative stress, proteases that might be involved in hemorrhage, adhesion molecules that might be involved in a prothrombotic state. But as soon as you reperfuse and you add oxygen to the mix, it's like you unleash a dam, and you have a major increase in plugging, in hemorrhage, risk of hemorrhage, and other kinds of oxidative injury as well. So can anything be done to improve outcome from hyperglycemic stroke? Well, unfortunately, the thing that we would think about, which is reducing glucose at the time of stroke, it looked promising in early studies, but when this was done in a large-scale randomized setting, it just didn't seem to improve outcome. nor in the ICU in general. The internists thought that treating high glucose might benefit critical care patients. Well, it didn't work. It could be that it wasn't targeting the right patients. Remember, those large artery atherosclerotic patients might have been the ones that benefit the most. So it might be that there's more potential in treating some of those mechanisms like reperfusion injury in general, vasospasm, platelet aggregation, post-therapy. But like with most things, prevention is probably better than treatment, and so we're wondering if better management of the risk factors for susceptibility to hyperglycemia at stroke might do a better job. And we're thinking specifically about metabolic syndrome, the pre-diabetic state, or insulin resistance. And we'll talk about that a little bit more. So that leads to the second part of my talk, which is about clinical disparities in stroke treatment outcomes. So disparities in stroke takes many forms. There certainly is an increased interest, fortunately, overall, in providing equal access in all phases of stroke care. We know some generally accepted differences in stroke risk factors, different stroke subtypes. The causes of these disparities are likely multifactorial, cultural, genetic, access to care. But one understudied topic is whether there are differences in response to stroke therapy based on race, ethnicity, sex, etc. But one consistent finding is their highest stroke mortality is in African American females. So why might that be? Well, research is difficult in this area because non-white representation in our RCTs is very low and continues to be low. Non-randomized databases are helpful, but they really can't control for why patients do or do not get a treatment. And our RCTs, unfortunately, still show a reduced non-white representation. And when there's small numbers, you inevitably get into imbalances between groups that are difficult to control for. So we explored this, and we used the NINDS TPA data set, and even though this had a relatively poor non-white representation, it was the most comprehensive data set available. We explored this data set. We matched very important baseline parameters like NIH stroke scale, so stroke subtype, etc. Looked at the influence of race and sex specifically. Now note there were only 90 total African American females in this NINDS data set, but nevertheless we were able to get some pretty good matching. And when we did that and we published this in Stroke, now about 10 years ago, the results are really striking. If we look at the benefit of TPA compared to placebo, and break it down by sex and race, you see that Caucasian males have about a 50% greater chance of an excellent outcome with TPA. It drops a little bit in African American males, drops a little bit more in Caucasian females, and is essentially zero in African American females. It's a caveat, of course. It's a retrospective analysis of an older data set. Turns out when we looked at outcomes in modern data sets versus the NINDS, they're pretty comparable, so it might be representative still of the kind of care that people are getting. And we did confirm a trend in a university data set that we looked at the same time. So if it turns out that this is correct, why might that be? Well, we looked at a number of different potential mechanisms that were listed in the TPA data set, other comorbidities, lab values, medications, etc. And it turns out that things that didn't influence was a chance of symptomatic hemorrhage, time to treatment, which was slightly higher in the African American females, but only about 10 minutes. Looked at other medical and historical factors. None of those were significant, except they had a 4.7-fold chance higher history of diabetes in African American women. And this difference occurred even though we matched for their baseline glucoses. So it suggested to us that maybe a prior history, a longer history of diabetes, or a longer history of a pre-diabetic state may have occurred. So fortunately, NIH funded us to do a prospective study that's ongoing right now, We're exploring clinical factors, RNA expression profiles. We're doing that in conjunction with one of the historical black college universities, Morehouse School of Medicine, where Roger Simon's the PI. We're recruiting in nearby Grady Memorial Hospital in Atlanta, where over 90% of their acute stroke admissions are in African Americans, and a high percentage of them get both thrombolytic and endovascular therapies. So, a summary, and I'll conclude. Disorders of glucose regulation appear to increase the chances of a poor outcome following stroke therapy and may potentially explain some disparities in stroke outcomes. So what can we do now and in the future to improve treatment response? Well, one is we probably need to give more attention to reducing this increased susceptibility to high glucose at the time of the stroke. More aggressive diabetes management and pre-diabetes management. We know obesity and a sedentary lifestyle lead to insulin resistance, and there's some evidence now that therapy with new line agents might be beneficial in the pre-diabetic state in reducing stroke outcome. One example is the IRIS trial, insulin resistant in stroke trial, published a few years ago, using polyglitazone, one of the TZDs. They do have side effects, and so we should pay attention to that. And if you're going to do that, we recommend that's probably best managed by each respective specialist. And we recommend that this be done proactively, that take the time to meet with the endocrinologist, the internist, hypertension management, and try to outline how it's possible to potentially be more aggressive in treating patients before their stroke. So I'll stop there. Thank you to the organizers. This is what provided my funding. And I guess we'll have questions after.